inside of cheek for last 3 months, decreased mouth opening for 2 months, ulcer over the outer cheek skin for 2 weeks, and swelling over the face for last 1 week. My patient was apparently well 3 months back when he noticed an ulcer over the inside of his cheek, which was insidious in onset, approximately 2 into 2 centimeter to begin with, at the posterior aspect of his inside of his cheek, which gradually progressed to involve the entire inside of his right cheek. The ulcer was associated with pain and burning sensation with spicy food. It was not associated with foul smelling discharge, excess salivation, or loosening of teeth. My patient also complained of decreased mouth opening for last 2 months, which was insidious in onset, gradually progressive to permit only one finger inside the mouth. He also complained of noticing an ulcer over the right outer aspect of cheek, which was insidious in onset, 1 into 1 centimeter to begin with, and progressed to the current size of approximately 4 into 4 centimeter, which was associated with spontaneous purulent discharge from the ulcer for last 2 weeks. He also complained of swelling over the outer aspect of face, which was involving the right side initially, which was just confined to around the ulcer, but now the swelling was going up to the eye superiorly and till the neck inferiorly, not associated with redness. He had no complaints of fever, no complaints of loosening of teeth, any dental procedures or ill-fitting dentures. He had no history of pain radiating to the ear. No, he had history of unintended significant weight loss, that was 10 kgs over last 2 months. He had no history of high-risk sexual behavior. He had no history of cuff, hemoptysis or bony pains. Past history: my patient was treated for carcinoma penis 2 years back. He underwent partial penectomy followed by radiation therapy. There were no other comorbidities. For the present complaint, my patient consulted a Ayurvedic doctor, for which he underwent some form of leech therapy locally over the ulcer, as well as some form of oral therapy, after which the patient said that there was a flare up of the skin as well as the ulcer over the outer aspect. Personal history: my patient is a vegetarian. He is a reformed smoker. There is a history of consuming tobacco in form of chewing, that is khenny, for last 20 years, which he has now left for last 2 years. There is 20 back years history of smoking, which was cigarettes. He has history of alcohol consumption for last 30 years. He consumed whiskey 30 to 60 ml twice a week, not consuming for last 2 years. There is no history of malignancy in the family, no history of changes in bladder and bowel habits. Sleep habits are normal. Summarizing my case: my patient is a 55-year-old reformed smoker, khenny chewer, and alcoholic with history of treated carcinoma penis, now presenting with a non-healing ulcer over the inner side of cheek for last 3 months, decreased mouth opening for 2 months, ulcer over the outer side of cheek for last 2 weeks with purulent discharge, and swelling reaching up to the eye for last 1 week.
Okay. So from your history, okay, since we last time discussed about the etiology and all the things that smoking, alcohol, so we'll not go into that. I think we stopped more or less after biopsy. So so from your history in brief.
Yes.
So what do you think is the stage of the disease? Is it?
Ma'am, since it has already involved the skin, it is at least a T4A. And since the swelling is going above the zygomatic process, it is locally unresectable at this point of time.
You mean to say it's not operable?
Yes, ma'am. It's not operable.
Borderline,
Okay.
na?
It's borderline unresectable. Yes.
So now you tell me, what are the things that what are the this one presentations that you say that they're not operable, like, or they're borderline operable?
Ma'am, there for inoperable there can be two subclasses. One which are anatomically they will never be resectable. That will include involvement of the prevertebral fascia, common carotid artery more than 270 degrees, or when then they will also be the anatomically those patients who can become resectable. These patients are the ones which are in the cases of a buccal mucosa. These are patients which have very widespread involvement of skin, edema going up above the level of zygoma, or involvement of the mesenteric space. For tongue, they have patients who are anterior two-thirds of tongue, the patients in whom disease is going below the level of hyoid anteriorly or below the vallecula posteriorly.
What is borderline operable?
Ma'am, borderline operable are these 5 conditions in which the patient may be given NSAT, and then depending on response, if the patient is operable, he might be offered surgery.
So there are few criteria which are inoperable. Few criteria, you mixed up both.
No, ma'am. The first two are the ones which will never get who will never be resectable. The ones.
Different patient treatment you told. Next,
Sorry, ma'am.
you told one is prevertebral fascia involvement.
Ma'am, the patients with prevertebral fascia involvement and common carotid artery are very advanced and they will never be resectable. The patients who are borderline resectable
And there
are
is skull base. Skull base is also.
Skull base involvement is one more.
Yes, ma'am. Yes, ma'am.
Skull base may be again their divisions.
Yes.
Okay. So the ITF, high ITF.
Yes,
so high ITF, you will not get the margin. So
yes.
Low ITF you can still get. Okay. Then what you told about edema reaching the zygoma.
For the buccal mucosa borderline operable is edema reaching up to zygoma, extensive skin involvement, and mesenteric space involvement.
Okay. So what is mesenteric space? What are the boundaries?
Masticator space involvement. Masticator space is the space which is between the two layers of deep cervical fascia. Its boundaries are inferiorly, it is going up to calvarium. Sorry, superiorly it is going up to the calvarium. Inferiorly it is going up to the lower border of mandible. Medially it goes up to the medial pterygoid muscle, and laterally it goes up to temporalis muscle. Masseter and temporalis muscle.
Mandible. Okay, fine. So now you are patient, you feel it is borderline operable.
Yes, ma'am.
Okay, fine. So
masticator space, ma'am, like masticator, even masseter involvement will be masticator. So is it borderline or high ITF is borderline?
High ITF is inoperable. Okay. Low ITF is borderline.
Okay.
Ma'am, when we say high ITF, we will say that lateral pterygoid involvement and temporalis involvement is high ITF, right?
Lateral pterygoid involvement, yes.
And will it also include temporalis?
It is very important for us. Actually, CTA हो जाता ना तो we would have been.
Ma'am, your voice is breaking.
Somebody
Everyone mute, please. Yes, ma'am.
Yeah. So, whenever there is, what is the main thing in oral cavity resections? We should get a margin. Okay.
Yes.
So, when it is high ITF, you won't get a margin. Okay.
Yes.
So, that is the problem. In low ITF, you do get a margin. Okay. The temporalis involvement itself is not criteria of inoperability. Okay.
Actually, ma'am, lateral high ITF is also two types: medial disease and lateral disease. If medial disease, a pterygomaxillary that fissure is involved or foramen is involved, then it's
No, the plates are involved, you can't. Okay. So that disease gets beyond deep into the skull base. So that's why you'll not get the mark there. Okay. So yeah. So you think your patient is minimum of here? No, you're taking
T4A.
body. Yeah.
Yes.
Okay. Then and any swellings anywhere? They have noted.
Ma'am, he did not say it in the history, but when I examined, I found nodes, ma'am, hard fixed nodes.
But he did not find it. Okay, fine. So you think it is a node positive advanced disease?
Yes.
Right?
Yes, ma'am.
So any history suggestive of metastasis?
No, ma'am, no history suggestive of metastasis.
Right. So in your case, do you think that this is the skin involvement that is leading to secondary ulceration and infection and leading to purulent discharge? Right?
Yes, yes, ma'am.
Okay. And he's an you told no reformed smoker. Smoking, did we discuss last time? Types of smokers and all?
Ma'am,
I think we did.
we did nahi, we didn't, we pack per year. You told ki next time come and read
Oh,
types
okay.
of that pack per year and कितना बीड़ी में कितना वो बंडल में कितना होता है.
Yeah. Okay, people read? Or you want me to tell?
Ma'am, please tell.
You want me to tell. So
Avneet,
how many
Avneet, have you read kya?
What ma'am told last time, I think it is 10 cigarettes in a pack and 24 BDs in a pack. The number of cigarettes that one smokes per day into number of years is the pack years.
Yeah,
formula is correct, but number of cigarettes is 20 as per USA. But in India, we get only 10 cigarettes per pack.
20, generally 20, okay. And BDs are?
24.
Yeah. So now, okay, let us discuss 5 to 10 minutes about smoking then, okay? Because we will ask about that. So sometimes they'll go deep into smoking and alcohol only in oral cavity cancers. So tell me, yesterday we have discussed what are the cancers that are caused by smoking, right? And now you tell me, like last time we have discussed smoked forms and smokeless forms.
Yes.
Okay. Can you repeat it? Can you tell for the benefit of others who did not attend?
Yes, ma'am. So there are smokeless form of tobaccos and there are smoking forms of tobaccos. The smoking form of tobaccos can be cigarettes, it can be BD, as well as there can be cigars. For smokeless form of tobaccos, there can be, depending on the various geography, it can be associated as betel quid, gutka, kheni, some form of manjan, or snooze, or zarda.
Snuff, zarda, khani, gutka, mishri, all this. Okay.
Most of them are tobacco, which is mixed with powdered form of betel quid as well as lime. So in these patients, the lime acts by raising the pH, and this raising of pH will release some form of alkaloids from both the tobacco as well as the betel quid, and will then generate reactive oxygen species, which will cause chromosomal damage.
Okay. Okay, fine. So, what is the electronic ENDs?
Electronic electronic nicotine delivery devices. These are devices in which there is a heating element. This heating element will increase the temperature, which will help in vaporizing the tobacco. So they will not form. I think they do not form smoke, but they contain the inhalational form of tobacco. And ENDs are also.
They contain nicotine, I think, not tobacco. Na, ma'am?
Only nicotine.
Because nicotine itself is not a cancer. It's like addictive. तो उनका एडिक्शन दूर करने के लिए हम निकोटिन दे देते हैं तो उनको
It is a nicotine vaporizing system.
Nicotine devices they contain nicotine. It's about 80% of the traditional cigarette forms, but they also contain carcinogenic agents that are there in tobacco. But it is less than smoked tobacco. Okay.
But ma'am, these are now not approved in the alcohol. So in the tobacco for the tobacco de-addiction, now these are not approved. No?
No, they're
Not
not
FDA
approved. I'm not asking about any patches and anything. Isn't it different? It's a device that delivers the same thing that is there in cigarette, but the carcinogenic agents will be little less. Still, they're carcinogenic. They're not less harmful than conventional cigarette. They contain 80% of addictive nicotine and also carcinogens. So these are things. So what is this? They can also be used to vaporize this cannabis. Okay, so they're not harmless. Okay, WHO has told they're still harmful. Okay, so who are never smokers?
Ma'am, somebody who has smoked less than 100 cigarettes in their lifetime and have not smoked in the last 2 months.
Less than 100 cigarettes in their whole lifetime. Okay, who have never smoked or smoked less than 100 cigarettes. Both are never smokers only. Yes. What are former smokers? Who are former smokers?
Former smokers are people who have smoked more than 100 cigarettes, but they have not smoked in the last previous 1 year.
They say that currently do not smoke. That's it. Okay. So
there is slight difference, I think. Last 1 year to last 1 week, I think.
Just hold on. I'm getting a hospital call. I'll just 1 minute. Hold. Who have smoked 100 cigarettes in their lifetime and are currently smoking. Okay, either daily or some days in a week or something like that. Okay, non-smokers who do not smoke, they are included both former smokers and never smokers. So these are the definitions. Okay. Clear or?
I think there is
1 week to 1 year वाले को क्या बोलना है मैम?
Sorry?
1 week to 1 year वाले को क्या बोलना है?
Recent.
It is recent smokers.
Okay.
Okay. So just give me 2 minutes. One hospital, this one is there. Okay. Just I'll come back. I'll join back.
Avneet smoked in a day multiplied by number of years of smoking.
Number of packs है, cigarettes नहीं है.
Number of packs into number of years.
Number of packs into number of
cigarette
years.
बोला था क्या? Sorry.
वो भी मुझे लग रहा है यार masticator space involvement तो मतलब masticator is like broad space ना, even masticator's masseter's muscle involvement है तो वो तो
उसमें भी ना पहले क्लासिफिकेशन मैंने पढ़ी थी मास्टिकेटर स्पेस में भी ना 3 स्पेसेस हैं उसमें मास्टिकेटर स्पेस लेवल 1 लेवल 2 लेवल 3 नीचे से ऊपर जाते हुए तो उसमें जो मास्टिकेटर लेवल स्पेस 3 है ना उसके अंदर आता है आपका टेम्पोरालिस एज वेल एज मीडियल टेरिगोइड लैटरल टेरिगोइड एंड टेम्पोरालिस उनका इन्वॉल्वमेंट फिर वही जो सौम्यता कह रहे थे ना कि फोरामेन आ जाता है उसमें तो masticator space level 3 is not operable. Masticator space level 2 and 1 are borderline.
उसमें भी एक नीरव त्रिवेदी सर का कोई आर्टिकल है
मेरे को इसका रेफरेंस नहीं पता
वो ही है उसने ये ITF को 3 पार्ट्स में डिवाइड किया है
so who are chain smokers?
Don't know ma'am.
Chain smokers is one who lights up the next cigarette when one is still in mouth, okay, and at least 3 packs per day they smoke. Okay, they are chain smokers. Heavy smokers are who smoke 2 packs per day, and moderate smokers are 1 to 2 packs, and light smoker is 1 pack, half to 1 pack. Casual smoker is only occasional smoker. Okay. So,
where can we find these definitions? Light smoker.
These are all in Devita here. They're all in Devita. Okay. I'll send you the like one PPT is there which has got about smoking. So I'll send you that. Okay.
Okay.
Then, yeah. So, anything else? We already, what are group 1 carcinogens? What are group 2A, 2B?
Ma'am, group
what is this groups? Who has classified this?
Ma'am, group, it is a IARC classification.
What is IARC?
International Agency of
for research in cancer carcinogenesis.
Yes. So group 1 is which is I'm not very sure, but group 1 is which is 100 which
proven
is
carcinogen.
Proven carcinogen. Class 2 is which is associated but not proven, and 2B is which has some form of association.
Type 2A is possible, type 2 no, type 2A is probable, type 2B is possible, and type 3 type 3
group 1 is carcinogenic to humans, probably carcinogenic is 2A, 2B is possibly carcinogenic. Okay. So what are the in cigarettes, what are the things that are there? Last time I think Soumyata told, but you can tell. Like
cigarettes contain tobacco. So tobacco will contain carcinogenic compounds which are different in the oral cavity as well as in the lungs. So NNN and NNK will be carcinogen in the oral cavity, and PAH will be carcinogen in the lung.
PAH and benzene and all those things.
Yes.
Okay.
Yes.
Right. So I'm not discussing about the pathophysiology behind smoking, alcohol. Last time we have discussed enough. So we'll not discuss that. Okay. So now, yeah, you proceed to examination. We'll discuss about the imaging and all today.
Examination. I examined my patient in a well-lit room with adequate exposure, informed consent, and in the presence of a chaperone. My patient was conscious, oriented to time, place, person. He was normal build, well-nourished, with a BMI of 27 kg per meter square, with a ECOG performance status of 0. You told ma'am we should write one. I made the BPT before.
No issues.
BP was 132 by 86 mm of mercury, taken in right arm supine position. Pulse was 88 beats per minute. The patient had no pallor, icterus, clubbing, cyanosis. There was no generalized lymphadenopathy, but there was cervical lymphadenopathy, which I would like to tell in the systemic examination. Examination of the head and neck region. On inspection, there was a swelling which was on the right side of the cheek, which was reaching up to the periorbital region superiorly, to below the level of angle of mandible inferiorly, reaching up to the commissure of lip medially till ramus of mandible laterally. There is a swelling with the swelling was irregular in shape with indistinct edges, and overlying skin over the swelling was normal except for a ulcer, there was no redness of the skin, but there was an ulcer which could be found. The ulcer was 3 into 3 centimeter, which was approximately 4 centimeter lateral to the commissure, which was ovoid in shape with distinct everted edges. There was purulent discharge from the ulcer from multiple sides. There was no visible swelling of the there was no visible swelling in the neck, except for the swelling which was continuous from the face, which was going below the level of mandible. Mouth opening, it was 1 centimeter interincisor. The distance interincisor distance was 1 centimeter. Orodental hygiene was poor. There were tobacco stains more on the lower gums than on the upper gums. He had no halitosis or loss of teeth. There was a ulceroproliferative growth, which was approximately 6 into 4 centimeter, which was occupying the entire surface of buccal mucosa of the right side, reaching anteriorly up to 2 centimeter short of lip commissure, up till the canine anteriorly, involving both the upper and lower gingivobuccal sulcus, reaching up to the retromolar trigone posteriorly with gross paramandibular disease. The tongue protrusion was normal, and there was no deviation of the tongue. There were no other lesions visible on inspection, but later, ma'am, I'll tell about the palpation.
So,
yes, ma'am.
did you tell about facial asymmetry?
Ma'am, there was this asymmetry because of the swelling, ma'am.
Yeah. So, in buccal mucosa, you should tell. In tongue, it is not required. Okay. So, that one.
Okay.
Yeah. Other than that, okay.
On palpation, I confirmed my findings of the swelling of the right cheek. The irregular swelling was reaching up to the periorbital region superiorly to below the level of angle of mandible inferiorly, commissure of lip medially till the ramus of mandible laterally. Temperature of the overlying skin was normal with no tenderness. There was hard induration which could be felt beyond the edges of the swelling inferiorly as well as laterally. There was an ulcer which was which was 3 into 3 centimeters, 4 centimeter lateral to the commissure, ovoid in shape, distinct everted edges. The temperature overlying the ulcer was normal with no tenderness. Floor was formed of the necrotic material and base was indurated. There were everted edges. The ulcer did not bleed on touch. Inside the oral cavity, the patient had submucous fibrotic bands on the left side of the oral cavity. There was ulceroproliferative growth 6 into 4 centimeter occupying entire surface of the buccal mucosa. There was paramandibular disease from the right RMT to 1 centimeter proximal of commissure. The gingivolabial sulcus and the floor of mouth were free. The overlying skin was involved. On neck, there in the examination of neck, there was a 2 into 2 centimeter hard nodal mass which was palpated in the right level 1B region, which was fixed to the mandible, but the overlying skin was normal. It was not attached to the overlying skin, and there was another 1 into 1 centimeter hard matted node which was palpated on the right side level 3. Thyroid was not palpable. Hopkins examination was normal. And to summarize my examination, my patient is a 55-year-old gentleman, reformed smoker, alcoholic and tobacco chewer with previous history of carcinoma penis, now with ulceroproliferative growth, right buccal mucosa involving upper and lower gingivobuccal sulcus and RMT with fixed hard level 1B and level 3 node with restricted mouth opening and submucous fibrosis.
You are stressing on the fact that he is treated for CA penis. Any reason why?
No, ma'am. In this case, not particularly.
It's an oropharynx.
Squamous cell carcinoma उसमें भी रहता है HPV.
Oral cavity, especially when she's presenting buccal mucosa, so it has not been proved. Okay, so
oropharynx HPV could be a factor, but not in buccal mucosa.
HPV in oral cavity cancers?
Ma'am, not. I don't think it is proven.
So there are some studies from French people, but they have seen association in around 15 to 20%. But 15 to 20%, 80% were not associated. So, but in long-term studies by others, it is not proved. Okay, oral cavity HPV association is not proved. Okay, other thing is okay. Go back to your.
If patient received chemo for penis, then it can affect NACT, like if it is recurrent.
Patient received what?
Like.
Your voice is not clear, Dr. Rakesh. Your voice is not clear.
Chemo for penile cancer?
Then, if recently received, then tip regimen is given there. So, can it decide affect the regimen in oral cavity if NACT is planned?
I don't think so. I don't think so, unless patient is not fit or something. But that chemo will not affect oral cavity chemo. Okay, if patient is fit, they will give chemo.
DFI do matter, kya?
Disease-free interval for what? These are two different cancers, no?
Between different two cancers. If इफ उसने एजुएंट टिप लिया है तो डॉक्टर एज पर डॉक्टर राकेश जो बोल रहे हैं उसमें भी प्लैटिनम होता है.
See, unless it has caused, suppose it is like bleomycin or something like that, okay, then some pulmonary function is affected where they cannot be given further chemotherapy, okay, then it actually matters. In this case, I don't think it really matters, okay. The only association here is for HPV. That too is not for oral cavity. If it was oropharynx or anything, yeah, okay. And high risk behavior, because he has CFNS, yeah, because he has CFNS, you're okay to tell that. But sometimes if you do tell that thing, that high risk behavior, then they'll ask you, is it relevant in oral cavity cancer?
For oral cavity, when asking for high risk behavior, can we state that we asked it for syphilis?
Where did you see syphilis here? None of us have seen syphilis.
Second primary rule out, we can rule out like
synchronous primary field cancerization is one thing, okay, but other than that, better not to tell high risk behavior in high risk in oral cavity cancers, okay? Unnecessarily they'll drag into oropharynx and how much HPV and all those things are not required, okay? So yeah. So
मैम ओकेशनल ड्रिंकर और ये इसका डेफिनेशन कहाँ से पढ़ना है?
Occasional, no, there is that is WHO recommended limits for each how much you should consume, okay. The actually like recent guidelines say that nothing is allowable limit, okay, in alcohol consumption, but previous definition it has given some amount for each type of alcohol consumed. I'll forward that to you, okay. So if you are asked now, as per recent studies, WHO has told there is no permissible or allowable limit for whatsoever alcohol consumption, okay. So next,
if patient is taking alcohol or either daily basis or occasional, it's like a patient is alcoholic.
Yeah, see, you should there is difference between addiction and habituation, okay. So don't tell he's addicted to alcohol consumption. So addicted means he cannot do any work without consuming alcohol. So addiction is something. So there are no habituations, you can tell, okay. So unless patient is used to take it daily, okay, without which he cannot do anything, then only they are addicted, okay. There are definition for addiction. So better not to tell addicted to alcohol, okay. So there is no habituations, not used to consumption of alcohol. That is safe to use. That word is safe to use, okay. So yeah, we discussed about trismus, right?
Yes.
Yeah. So last time I told you, no. So what are the trismus grades?
Ma'am, there is a SOMA classification which is is read. The SOMA classification says that if the inter-incisor distance is more than 3.5 centimeters, the patient has no trismus. If it is 3.5 to 2.5, it is grade 1. 2.5 to 1.5 is grade 2. 1.5 to 0.5 centimeter is grade 3. Less than 0.5 is 4.
So what is this OSMF?
OSMF is a oral, oral premalignant disorder. It is a oral premalignant disorder in which there is replacement of the submucosa by there's replacement of the submucosa by collagen, and then there is atrophy of the overlying mucosa, which leads it to increased propensity for malignancy.
Okay. So what are grades? Khanna and Khanna classification. Grades.
Not aware, ma'am.
Okay, fine. So last time I told you, I think, no? If there is asymptomatic, only burning sensation, and then there will be appearance of erythematous lesions. Then there will be bands. Then there will be trismus. Okay.
Okay.
So that is about the grading of submucosal fibrosis. Okay. So who told if a patient has OSMF, is his prognosis good, bad?
Ma'am,
What do you think?
he has a high, ma'am, OSMF is a high risk OPMD, so his prognosis is bad, ma'am.
No, it's the other way around. Why? Anyone can tell why?
मैम
His prognosis is good.
local spread पे कोई cover रहता है क्या मैम, like if fibrosis is there?
Collagen
There's
deposition.
fibrosis, no. There is fibrosis, no, that prevents spread of the disease. So they from one layer to other layer to spread and get infiltration, they have resistance to infiltration. So the OSMF has better prognosis. This was studied by Pankaj sirs. Okay.
Ma'am, OSMF does affect the lymphatic spread, ma'am. Any fibrosis.
That's what. There will be delayed infiltration and delayed lymph nodal spread in OSMF. That's what they told in that study. Pankaj Chaturvedi sirs.
Ma'am, that has 3 stages. Now, this fibrosis is starting from grade 3.
Yes.
उसमें grading में they have divided into 5 components: clinical,
first
functional,
one is
and
like
histopathological. So grade 1 clinical में they are, that is mild blanching and burning sensation, and dryness of mouth, and mouth opening is also there. In functional we have to see mouth opening. And histopathological में stage of inflammation. In grade
Yes.
2, it will involve 1/3 to 2/3 of the oral cavity. उसमें less than 1/3 in grade 1. Grade 2 में 1/3 to 2/3 of the oral cavity with the blanching of oral mucosa and mottled and marble-like appearance, and fibrotic bands are palpable.
Yes.
In grade 3, more than 2/3 of the oral tongue or tongue floor of mouth या फिर lymph adenopathy is there, then it is grade 3. Mouth opening in 3.5, the 2.5 to 3.5, and grade 3 में 1.5 to 2.5 only. And cheek flexibility is also reduced by 66%. उसमें grade 2 में cheek flexibility is reduced by 33%. And stage of hyalinization in grade 2, stage of fibrosis is in grade 3, and malignant transformation is stage 4. In leukoplakia, erythroplakia, ulceration, and suspicious malignant lesions, all are coming in grade 4.
Yeah. So simple way to remember is, first they'll have only this mild symptoms, that is burning sensation, okay, and stomatitis will be there. Then second phase में जो है, you will be able to feel the thin fibrous band, but only there will be a little bit of blanching, okay, and mouth opening will be little bit restricted, okay. And next phase it will be much restricted mouth opening, okay. There will be very much established blanching with formation of thick bands, okay. There thin bands, here thick bands, and finally when there is establishment, that is ulceration and all will come to 4, okay. Easy way to remember it. Then yeah. So next, so you told me it's extending from almost anterior end to the RMT, okay, right?
Yes.
So is RMT involved or not involved?
RMT is involved, ma'am.
So what are boundaries of RMT?
Ma'am, RMT is a triangular area which is it's a triangular fossa which is just posterior to the last last molar, that is third molar. The anterior boundary is the third molar and the posterior boundary is the maxillary tuberosity. The lateral boundary is the buccal mucosa, ma'am.
So maxillary tuberosity, third molar. And so why are we concerned about RMT lesions? Why it has got so much importance?
Ma'am, because RMT lesions are prone to spread in a lot of directions. If the RMT is involved from the retroenteral area, it can involve the infratemporal fossa. If it spreads medially, it can go towards the oropharynx. If it spreads superiorly, it can go to the pterygopalatine fossa. But mostly towards the retroenteral area, it can involve the ITF.
Yeah. So where from the RMT, because of the lack of the periosteal lining there, so and more of the neural involvement, so they spread easily to the like they compared to the anterior 2/3 lesions. Okay, RMT areas are more found to be aggressive in short span of time because of the thin periosteum as well as perineural invasion. Okay.
Yes.
So yeah, next anteriorly up to lip. So now it's extending 2 centimeters short of lip commissura. I'm not able to see it properly here. So where is it not reaching the angle of the mouth?
No, ma'am. It is reaching short of the angle of mouth.
Okay, fine. So right. So why am I asking this?
Ma'am, it will depend, or it will change our surgical approach whenever we take one, because if it is involving the lip commissure, we'll have to take a lateral lip split incision, which will involve the.
What is the difference between angle split and midline split?
Ma'am, midline split is a row or trotter incision. It is usually taken when the disease is when the disease is involved when the disease is a posterior disease and it is not involving any of the lateral commissures. But whenever there is involvement of the lateral commissure, we like to take the lateral lip split, which is the Grogg's incision.
So has it got any relevance to the arterial supply? What is the crossing over of the arterial supply in lip?
Ma'am, labial arteries, we like to preserve the commissure of the lip because
लेबियल आर्टरी का सुपीरियर इंफीरियर ब्रांच और एंटीरियर पोस्टीरियर में वहाँ पे डिवाइड होता है, वहीं से पूरा कमिशर से ही आता है टुवर्ड्स द मिड लाइन ना मैम.
And whenever it is involving the commissure, so whenever your reconstruction should entail, you should keep it in mind that they shouldn't get microstomia. Okay.
yes.
So that is one thing, and this vascularity, that labial artery supplies, that which matters when it is involved in the commissure. Okay. So yeah. So in tongue, no, last time I forgot to ask. So why is there ankyloglossia? Soumyata, you can tell. You presented tongue, right?
Involvement of floor of mouth, ma'am.
So what is that?
Ankyloglossia, tongue is not able to protrude out of the mouth. This is ankyloglossia. And when the ulcer is when floor of mouth is involved in CA tongue, the patient is not able to protrude tongue out of the oral cavity.
So it's one of the indication that it's an advanced disease if it occurs in CA tongue. Okay,
then we need to do compartment. We discussed that. This I think.
Yes. So OPMD also we discussed last time. Okay. So next page. Always make it a point to put dental formula. Okay. Last time also I told.
Okay.
In which we are not able to see the teeth, oral cavity in trismus, then what we will do then?
Then it is only to the extent visible. You will describe the ulcer also. That time it's not required. But when you are describing here, there is little amount of trismus. But when mouth opening is adequate, then better describe the oral, the missing teeth or sharp teeth that are important. Okay. So in trismus, they won't. When mouth opening is restricted, they won't ask you. But in other cases, you tell poor orodental hygiene. No, what is poor orodental hygiene? What has it got to do with the? Are there any studies which say that poor orodental hygiene is one of the etiology factors, etiological factors, or something?
Ma'am, there are studies to say that poor orodontal hygiene is associated with the increased risk of carcinoma, but I'm not aware of the author.
Yeah, it was from Tata only. So it is one of the see, there are established risk factors. Okay, that possible risk factors. So it's one of the possible risk factors, but not established. Like smoking, alcohol, they are independent risk factors. Okay,
Yes.
These are associated risk factors. So secondary to secondary infection and all that causes irritation, that causes cancer, release of carcinogens and cancer. So that is indirect way of causing carcinogenesis. They're not independent risk factors.
Okay.
Okay. So can you tell me the staging of oral cavity cancers?
Yes, ma'am. The
Buccal mucosa.
Ma'am, the TNM staging, T1 will be tumors which are less than 2 centimeter or depth of invasion less than 5 mm. T2 is tumors which are 2 to 4 centimeters or depth of invasion is less than 10 mm. T3 is tumors which are more than 4 centimeters or depth of invasion is more than 10 mm. T4 is further divided into T4A and T4B. T4A is involvement of the skin or involvement of the cortical bone. T4B is involvement of the masseter space. The T4B will involve the masticator space or common carotid involvement or prevertebral fascia involvement or skull base involvement. End staging and clinical end staging, ma'am. N1 is single ipsilateral lymph node which is less than 3 centimeters. This is non-HPV P16 negative for oral cancers only, ma'am. For clinically N2 is clinically N2A is single ipsilateral lymph node which is 3 to 6 centimeters. N2B is multiple ipsilateral lymph nodes which are 3 to 6 centimeters. N3 will be contralateral or bilateral lymph nodes which are less than 6 centimeters. N3 is any lymph node which is more than 6 centimeters, or N3B will be clinically extranodal extension whenever seen. For stage grouping, ma'am, T1 is stage 1, T2 is stage 2, T3 is stage 3. Any node positive N1 disease is also stage 3. T4A is stage 4A, T4B and N3 is stage 4B, and any metastasis is stage 4B.
Okay. So, what were the changes that were there in TNM staging compared to 7th and 8th?
Ma'am, first of all, the depth of invasion was included as an independent criteria in the staging. The lip as a subside of the oral cavity was divided into the buccal mucosa, which was from the cutaneous and mucosal junction. The area which was interior to the cutaneous mucosal junction was considered as oral cavity, and HPV positive and negative were two different. The end staging was different for HPV positive and negative. The nodal staging for HPV positive was N1 is less than 6 centimeter node.
Hello? Yeah. So now, so yours is T4A and 3B.
Yes.
Okay.
Yes.
So stage 4B.
Ma'am,
so
I had a doubt. Ma'am, will having edema reaching up the zygoma involve the masticator space involvement, ma'am?
See, it's not only clinical, but it's one of the clinical aspects of borderline inoperability. But you should also correlate it with radiological. findings.
Ma'am,
Okay?
as long as if I am not able to see, if I don't have the imaging and I only have the skin involvement and the bone involvement, if I can see gross paramandibular disease, just on the basis of the edema, I cannot say that my masticator space is involved. So I shouldn't be labeling it T4B unless I have a radiology, no?
Yeah, you have to correlate with radiology. Okay. Only clinical is not right. Okay, it might be possible to be it might be possible that it is borderline inoperable, but you have to correlate with it radiologically. You can tell examiner, I'll correlate radiologically and then take a call. Okay.
Okay.
So now you tell me what.
Soumyata ma'am, mute please.
Soumyata, I'm muted.
Hello?
I think somebody will have to call her.
But she is on call only.
Okay, no problem. Okay. So,
So, ma'am,
now
one thing I want to ask in this, ma'am. Like in examination, she wrote GBS is involved, upper and lower.
One more thing I wanted to point out. Why did you tell about ear pain in buccal mucosa?
Ma'am, because in buccal mucosa, if there is involvement of any part of tongue or in the auriculotemporal nerves, they can.
No. Your lesion is not involving tongue, right? So, what is the nerve that is likely to be involved in your case?
Yes.
You would have told that would be relevant.
Ma'am, buccal.
No, auriculotemporal, all that will come for tongue here. Something very simple. There will be paresthesia of chin.
Yes, ma'am.
Mental nerve.
What is that?
Inferior nerve.
Yeah. Okay, so marginal mandibular nerve. Okay, so and that is more relevant in your case, not tongue. Not ear pain. Okay, so
buccal nerve lead to, ma'am, like buccal nerve can also act as afferent for auriculotemporal, like referred.
What?
Buccal nerve.
No. What is the pathway buccal nerve ka?
Buccal nerve, the same pathway the lingual nerve take. Like
No. Only area where buccal mucosa lesion can cause this one ear pain is when it is reaching properly into RMT. There is at the lingual nerve crossing, it involves on either side.
Ma'am,
it crosses the RMT and reaches the other side of alveolar gingiva. Then that is the lingual aspect of the gingiva. Then
ma'am,
there might be enough.
Inferior alveolar nerve and buccal nerve, can we not say that also synapses with the auriculotemporal nerve, ma'am? The lingual, buccal and inferior alveolar nerve, they...
No, yeah, that is not the pathway. Okay, not common pathway to be involved. In buccal mucosa, it is, if you get something, it is paresthesia of the chin. Okay, in tongue, you can tell all these things. Okay, depending upon anterior 2/3, posterior 1/3, posterior most. Okay, so but not in this one, because some examiners will get annoyed. I don't know if you people have seen ISO oral cavity when Gaurav presented that Vijay Kumar sir, he told the cranial nerve involvement and all. So
Yeah, yes,
he was
ma'am.
behind that. So don't tell what is not relevant. Okay. So common pathways first. Then they'll go deep into anatomy, what trace this nerve, trace that. Not required, no? So be as simple and it should be common involvement. Okay. So yeah. So now what do you want to do? You want to do it?
Ma'am,
Few investigations to confirm your diagnosis, stage the disease,
and treat the patient, ma'am. Yes, ma'am.
Yeah.
Ma'am, I would like to take, for confirmation of my diagnosis, I would like to take the punch biopsy from the most representative part of the lesion. For staging my disease, since my patient has a bulky nodal disease, I will like to also do a metastatic PET-CT for metastatic workup, as well as an MRI for the involvement of the masseter space. And then if there is involvement, since the zygoma, the edema is reaching beyond the level of zygoma, treatment wise, I want to start the patient on edema.
Okay. So you prefer doing an MRI in this case?
Ma'am, that also I had a doubt. In my institution, they say that for any time where we have a masticator space, like we follow that, but I could not find the literature for it. I also asked my faculty.
No, it's correct. The indications for MRI to see better is perineural invasion
And
IPF involvement, this one, neurovascular bundle involvement. Okay, all these are indications for MRI. The standard investigation, if you are asked in normal oral cavity, is what?
CECT face and neck, man.
CECT?
Face and neck and non-contrast CT of the chest.
CECT neck, including oral cavity with?
NCCT of the thorax, ma'am.
No, there is some maneuver, no?
Puff cheek maneuver, ma'am.
Yeah, so that is important. Okay,
ma'am.
So that is not
MRI. As in, we have read mostly
in
that
this
MRI.
case of yours. In this case of yours, you are not wrong in telling an MRI. Okay, so
is it standard to use MRI for masticator space involvement, or should I not say this in exams?
Rather than masticator space involvement, you can support your statement by saying it's reaching the RMP. So I would like to see, and since there is trismus, okay, I would like to look at the perineural invasion and neurovascular bundle involvement. So I would like to see MRI as well as because I also suspect the masticator space involvement since clinically trismus is there. In this case, MRI would add on to my findings compared to CT. So that way you can support. Okay, if you are telling MRI, you are not wrong in telling MRI, but the standard investigation CT is fine unless there is like in your case, it's going above the zygoma. Okay, yes. And it is reaching the RMT. All these are indications that you're not wrong if you tell MRI. Okay. Yeah. So you tell CCT neck with including oral cavity. Okay. Yes. So what is the extent that they take for CCT neck?
Sorry, ma'am, I didn't get you, ma'am.
What is the upper limit of the
base of skull, ma'am?
And what is the lower limit?
Clavicle, ma'am.
Yeah. So that's what you want, no? So, and oral cavity will be covered with puff cheek. So yes. That is what we require. Okay. So now, yeah. So tell me, we have discussed about margins last time. Okay. Yes. So we have discussed specimen-directed, patient-directed margins. So any additional, like you have any additional techniques for margin assessment other than protein biopsy or anything?
Yes, ma'am. For the margin assessment, we can do various. As we know, we can take frozen section analysis. There are other modalities that we can use, like we can use intraoperative ultrasound, use of contrast dyes like toluidine blue. We can use near infrared spectroscopy. We can use Raman spectroscopy and near infrared imaging for margin assessment.
Okay. So one out of box question, but just like that. Can you tell me some one study which has told about screening in oral cavity cancer? It was the one study which had been applauded because of their work. So almost 12,000 cases they have done. So do you know that study?
Yeah, Shankar. They had taken the saliva sample.
Yeah, Shankar et al. From Shankar et al. The study is Shankar et al. Okay. Okay. So, okay, I ask you, does the quitting of smoking in your case, first of all, and when you tell about the management, no, first thing, whoever is smoker or alcohol addiction, first thing you should suggest is de-addiction. Okay.
Yes.
Then to proceed, I will explain about the management plan of management. So this would be my investigations. Okay, this would be for my confirmation of diagnosis, and then plan. This would be my surgical plan. Okay. So in this case, do you have any MRI films and all?
Yes, ma'am, I do. Uh, this is a T2 weighted axial image of axial MRI of my patient. The axial MRI shows from the outside to the inside, ma'am, there is edema of the skin with a hyper intense lesion which is involving the skin, the buccinator muscle, uh, the uh, the skin buccinator, the buccal mucosa. It is causing gross paramandibular disease. The fat planes with the buccal plate are also lost. The fat planes with the buccal plate are also lost. However, there is no involvement in our MRI scan. There is no involvement of the masseter as well as the medial pterygoid muscle, ma'am.
Okay. Anything about perineural? How do you see perineural invasion in MRI?
Ma'am, there are widening of the foramen, the neural foramen, and there are signal voids which can be seen.
Okay.
Edema and
basically edema and widening of the foramen. Okay. Yeah. So, last time I asked you PNI divisions.
Yes,
I mean PNI types. So, did you read up?
Ma'am, PNI can be if there are. Ma'am, I don't remember the exact.
Intratumoral, extratumoral PNI and focal and diffuse PNI, na ma'am?
Yes, correct. And there were also division less than 2 centimeters, more than 2 centimeters. So, but the involving one nerve, major named nerves or
named or yes.
So, and one or many, like all this were classification.
Unnamed wala is a PNI, na ma'am?
Named and unnamed.
Unnamed
that was
nerve.
Named is PNI only, no?
That's what मतलब definition में unnamed लिखा था. That AJCC one which I read. तो I was thinking कि if named involve होगा तो क्या बोलेंगे?
There is an article I forgot by whom, but there is entire thing is on only PNI. Okay, I'll forward that. Huh?
Okay.
Remind me, huh?
Okay.
So, yeah. So now, so based on MRI, what additional findings you found in addition to your clinical examination here?
Ma'am, the medial pterygoid and masseter were not involved. That is one thing that we could find out, and there was bony involvement. That is one thing that we could assess, and
there was paramandibular disease.
Yes.
Right. So your whatever marginal and all is not possible, right?
Yes.
So yeah, we'll discuss about that. Then there's no PN.
Okay. Yes, no PN.
Tell me, so what are the layers of cheek that I asked last time?
Ma'am, the layers of cheek from the outside to the inside, there is, or from the inside to the outside, it is mucosa, submucosa, buccinator muscle, fat, and skin.
Okay, what is the thickness of cheek?
That I don't.
1 centimeter. 1
3 centimeter.
1 centimeter is correct. 7 to 1 centimeter. Okay. So, what is the layer in the cheek, the breach of which actually, you can tell that skin will be involved?
Buccinator muscle.
buccal space vaccinator.
Yeah, skin tethering, ma'am.
What?
Skin tethering अगर मतलब skin tethering in clinical examination.
So whenever this, what is tethering due to? It is same principle as in breast. What is tethering due to?
कुछ Cooper ligament तो नहीं होता इसमें.
नहीं. Tethering is involvement of skin or not there?
We are removing, but in final histopathology, most of the time it comes like skin is not involved.
Ma'am, skin involvement is polyarch ulceration and satellite nodules. No other thing is skin involvement.
Not skin involvement. So tethering will not involve skin. Here also the tethering is not skin involvement, but as a part of clinical report, that's skin. Okay, so it matters to you in surgical management. Okay, so but whenever it is close or breaches the buccal pad of fat, then it is buccinator muscle. Then almost always it involves skin. Okay. So and yeah. So other than MRI, anything else you want to do?
Ma'am, since he has heavy nodal disease, I would also like to do PET CT.
What is your stand doing a PET CT here?
Ma'am,
which disease will mandate a PET CT?
Ma'am, heavy nodal bulky nodal disease, as well as whenever the patient is symptomatic.
And when the level 4 nodes?
Yes, okay. Lower level nodes. Yes.
Okay. So now you tell me what are what are the methods or the ways in which mandible gets involved?
Ma'am, it will differ in edentulous and dentulous people. In dentulous people, it will be through the occlusal surfaces. In the edentulous people, these will be through the occlusal surfaces, and in dentulous people, it will go through the abutment of the cortical. It will be through the abutment of the cortical plate, and it can also involve the foramen. The mandibular foramen, or through the inferior alveolar, the mandibular foramen or the mental foramen.
There are 6 ways. Whose paper was it? The ways of mandibular involvement?
Brown's, Scott and Brown's.
Yeah, Brown's paper. Yeah, you tell me. Think and tell. One you told us through direct infiltration, then the occlusal surface, then
mental
reflected
foramen.
mucosa, mental foramen. Before you go.
Two there.
Ligament and like from node also it can be from the flat nodes, lower body, say.
Yeah.
And ligaments, periodontal ligaments, something like that. Periodontal or something, I'm not getting exact name, but periodontal ligaments.
Through occlusal route, through periodontal membrane, through attached gingiva, via mental foramen, via mandibular foramen, through abutting lower mandible in the neck, and cortical bone defects in the edentulous ridge.
Cortical bone defects in the edentulous
ridge,
reflected part of mucosa. Okay. And as he told, the neck nodes, occlusal root, mental foramen, and mandibular foot. Okay, these are the roots. Okay. Then what? Okay, you tell me what are the indications for marginal mandibulectomy? What are the otherwise, in other way, you can tell contraindications.
Ma'am, contraindications for marginal mandibulectomy are edentulous patients who have received radiation to prior when there is gross paramandibular disease, when there is frank cortical invasion.
So what is your concept in doing a marginal mandibulectomy? In this case, we will not do a marginal mandibulectomy. So what is most essential feature that should be there to do a marginal mandibulectomy?
We should be able to preserve 1 centimeter of the height of the mandible, ma'am.
That's correct. You should be able to preserve 1 centimeter. So why 1 centimeter? Why not 0.5? Why not 1.2?
Ma'am, because the
This answer, ma'am, I didn't get. Which paper? I don't know.
So they have done they have done a very crude experiment. Okay, so they have put weights on kept on dropping weights. Okay, with this much height and all. So they have done this through, what do you call that? The wine is stored in one bottle, no? So they have kept on putting weights on them, and they saw with how much amount of weights the mandible is getting this bottle is getting fractured. So this was a crude experiment performed, but with that they have determined that 1 centimeter is safe, below which there is chances of mandibular fracture.
मैम पेपर का नाम क्या है?
पेपर का नाम नहीं है, ये तो एक एक्सपेरिमेंट से ये हुआ है. So they kept on doing that, and then they found that this 1 centimeter is safe.
And every edentulous patient is contraindication, or just edentulous with pipe stem mandible?
Most of the what is the mechanism of mandibular invasion in edentulous patients?
Occlusal surface, and then the canal comes superior.
Cortical defect.
No, cortical bone defect. Okay, their cortical bone defect will be, they'll have high risk of mandibular invasion because of the cortical bone entry. The tumor entry to cortical bone defects. Okay, so generally in edentulous patient you avoid. Okay, pipe stem mandible.
Disease is not reaching up to the mandible, but for margin we can go away with the marginal if it is not pipe stem. That I wanted to ask.
Yeah, a pipe stem you will not get the cortical height. Okay,
Yes.
so that is the problem.
Ma'am, I somewhere that whenever we have the masticator space involvement